This week on the BackTable podcast.
I had a oncologist reach out to me about a intrathecal chemotherapy injection, and I was just kind of like, yeah, I'll do it. I want to say yes to everything, but I hadn't gotten any ports or anything like that. Obviously, everyone's competing for ports. For some reason, everyone else loves doing them too. I said, yeah, I'll do the intrathecal. I'll help you with it. I'll help you. It's a new service line. We didn't do that in the hospital. I helped set it up. And the next week I got a text for, a couple of ports and other procedures that, allowed us to build that service line. So you're right. Like, you cannot be above anything. You have to be, the 3 A's of being a good radiologist. You have to be affable, available, and I don't know what the third A is, but I'm sure it's important too. Awesome. Able.
This is Mike Barraza, return as your host. I'm joined by Dr. Waqaar Diwan from Minimally Invasive Specialists of Texas. We're going to talk about the landscape for independent IR. How's it going, man?
Great. I'm happy to be here.
Good deal, man. Well, I want to talk a bit about your experience as an independent interventional radiologist and then talk more about the landscape in general. Let's start with you. How long have you been out of training?
So I graduated in July of 2024, so have not been out for that long, but in that short period of time that I've been out, I've kind of seen a lot of different aspects of the interventional radiology and radiology in general market, and been exposed to a lot more than I ever anticipated being exposed to early in my career.
Where did you train?
So I did my residency at Baylor in Dallas, BUMC, and then I did my fellowship at MD Anderson in Houston.
Nice. So what was your process like as you started, talk about when and how you started to look for jobs and how you started to kind of settle in on something?
Yeah, so I always had an idea of what I wanted my practice to be like, and I really wanted, coming from a place like MD Anderson, where I was exposed to all facets of interventional radiology. Most people don't know, but you train at 5 to 6 different hospitals, so it's not just oncology. There's level 1 trauma experience, PAD experience, and all of that. So I wanted a kind of full breadth of interventional radiology in my practice. And then obviously, being in Houston, I'm born and raised in Houston, so I really wanted to stay in town. I knew kind of the market in Houston, and the market in Houston is, one of those places where really the true pure IR jobs didn't really exist anymore.
Right.
And all of them are these hybrid jobs that sold to private equity. I mean, it's a huge percentage of the jobs. So I just kind of looked around. I interviewed at a couple places, and then one of my buddies who was already practicing at a hospital in Houston, he kind of reached out to me and tried to recruit me over the course my entire fellowship. He was trying to recruit me to come join him. And he was just kind of always harping on the fact that at this hospital, we get to do kind of all aspects of IR. And this is one of the few places where you're going to get the full breadth, including PAD, which is kind of hard to find.
Very hard to find.
So, and then there was obviously opportunity to grow. I wanted a place where, at least on my IR jobs, I wasn't under the delusion that I wasn't gonna have to do any DR, but at least on my IR days, I did not want any DR responsibilities, because I just think like it's almost impossible to focus on doing good IR if you also have to worry about a list blowing up behind you. So those are some of the things that I looked for when I was trying to find a job, and I landed on this hospital. And like I said, my buddy was recruiting me for almost a year. He kind of was talking to me about it daily, and initially I was like, there's no way. And then by the end of it, I said, you know what, this sounds like, after kind of looking at the landscape and all the other jobs available, I said, this is kind of the perfect opportunity for me.
Your friend that was there, is he, or was he before you joined, working directly for the hospital or just kind of on his own?
No, so our job changed dramatically only in the last couple months. So initially, we were part of a standard traditional private equity backed group. That's what I signed up with in July. So when, I waited until the very last minute, and then I finally signed the contract. And so I signed in, I think, the end of June or something like that. And then like a week after I signed, my buddy texted me saying, hey man, so this is a group of 6 radiologists that just cover one hospital. So it's a very small private equity backed group. Yeah.
Okay.
And so 6 IR DRs. Out of that, there are 3 IRs, and then there's 3 DRs, and that's all they have. And so one of the IRs, who'd already given up doing IR, but really was just in the call pool, said, you know what, I don't want this anymore. I just want to be a diagnostic radiologist, and put in his notice. And so from that point on, it set off a chain reaction where I find out in June, right after I signed the contract, that the group is actually probably going to implode. Yeah. And it doesn't look like the group is going to exist anymore long term. And so slowly everyone starts putting in their notice. I put in my notice as quickly as I could, and I had negotiated the shortest exit out of everyone. So everyone else had 6 months in their contract that they had to work, and I negotiated 4 months. So I did my 4 months.
At the end of your fellowship.
At the end of my fellowship, literally, I negotiated the 4 months, and so I put in my notice, and so then I was basically out of the contract before everyone else, and I negotiated my locums kind of contract to be able to stay on, but obviously at a much different rate. And during this process, so between when I graduated in July, started in August, and throughout August to pretty much a couple months ago, there was just this question in the air, like, who's going to get the contract? Like, is the big private equity group going to get the contract? Are they going to retain some of the rads? Someone else going to come in or not? And so during this process, me and my partner were the only two IRs that want to stick around. And we said, we're the only ones out of the 6 that want to stick around. Let's figure something out. And so during that process, basically where we ended up is essentially we're subcontracted out for the interventional radiology part of the contract. And then there's a remote tele diagnostic radiology group that covers the diagnostic radiology for the hospital.
So you work for the hospital providing their interventional radiology.
So I'm employed by that group, that diagnostic radiology group, but they subcontract out the IR to us. So essentially the bottom line was that the hospital that I work for in particular does not have any experience billing for IR, and they don't have experience from that end of it. So they didn't want to do with that. So they'd rather someone else do the billing and handle all that.
So the idea was that the old group, they weren't disappearing, but they weren't going to cover IR anymore.
The old group left, like all the other diagnostic radiologists left.
There's a new group
they had already signed other jobs.
And they're paying you guys to cover IR.
Exactly.
Sounds great.
Yeah, that's kind of as close to the dream as possible, So yeah, we were glad to be in that position.
So, how did things change once this happened, in terms of your day-to-day? I mean, obviously your responsibilities change,
So the biggest thing is anytime that we were on IR, there was a diagnostic radiologist on site as well during the normal hours. So the diagnostic radiologist handled the fluoro, handled all the barrage of questions from physicians, people coming in for curbside consults and this and that. And the IR did the IR and all of that. So with the exit of all the on-site diagnostic radiologists, we became the only on-site radiology presence. And so we switched from a model of like diagnostic radiologists and interventional radiologists on-site to one IR on-site and one mid-level on-site.
Yes.
And the diagnostic guys are all throughout the country.
Yeah.
And so obviously fluoro kind of it becomes our responsibility as well, kind of handling. We are basically the liaisons of this hospital contract, and we're basically the face of the hospital contract. So any issues that come up or anything like that, we are kind of involved in that. We help kind of navigate that. And then also, early on while we're still recruiting and credentialing our mid-level, we were in charge of kind of everything in the hospital. So initially there's some growing pains, but it's leveling out.
So where the group that hired you, where are they centered?
Honestly, they're just centered all around the country. Yeah. So they're just kind of, I think, more of a teleradiology group, and then their model is to subcontract out the interventional radiology portion of the contract in the hospital. So essentially the IR portion, you kind of function independently, but you're under the arm of the other group. But it's as close to kind of independent IR as you can get without being directly employed by the hospital.
What about the PAs? Are they hired by that same company, or do they work for you?
Correct. They work for the other company. So they have different models. In our model, the PA works for the company. So they have access to, all the resources that a big corporation or group or company has, and things like benefits and all that. So that was an advantage for us, that we don't have to kind of try to figure out how to provide that kind of stuff 6 months out of training.
What kind of stuff are the PAs doing?
So we're still working on the credentialing process because all of this turnover happened over the last month or anything, but mainly it's going to be assistance with non-tunneled lines, paras, thoras, and then the goal is really to get the diagnostic fluoroscopy stuff kind of offloaded to the mid-level.
They do that in my group, and it is truly a game changer for freeing you up. What about you? Now that this has changed, like what are your goals moving forward in this hospital?
Yeah. So the number one goal, initially it was all about OBL, and that was kind of the ultimate goal. But as this kind of situation and opportunity came around, it's kind of changed what the goal is. And the goal is really to build a solid practice and continue to build on the momentum we have, build on peripheral arterial disease treatment, build on all the different whole gambit of IR treatments that we do, from GAEs to PAEs, UFEs, and things like that. And then just from like a operational standpoint is to really build up the mid-level and his kind of role and kind of take advantage of the billables that a mid-level can generate, like things beyond doing just procedures, but also things like consults, kind of mold our practice into a more focused on clinical IR, meaning, writing on consults, follow-ups, all that stuff that just one IR doesn't have enough time to do on a day-to-day. But now that you have, an extender with you, to really kind of build on that aspect and make sure that you're really focusing on the clinical IR, and that physicians that consult us and order things to us know that we're going to be on top of it, and we're going to have a full clinical practice on how we approach things.
How does that change for the clinicians in the hospital, working with you and your partner instead of a larger group like they've been working with before? It's probably a little bit easier to work with interventional radiologists who are strictly there to provide IR services.
Yeah, I mean, I think definitely there's a huge advantage to that. The good thing is the people before me, again, it was a 6-people group servicing this hospital only. They were servicing anywhere else. So they had, before us, there was a couple of radiologists, interventional radiologists that had been there for like 20 years or so. So they're used to that kind of, personal white glove service. So that didn't change as much, but, it left a good kind of pattern that I knew to follow once I became a practicing physician.
Yeah, in terms of like getting consults and everything, is it, the process still the same? Is it mostly from, in-house procedures, or are you getting, stuff from outpatient?
So that is actually one of the big changes. The old big group had people that were hired to be kind of like our front office person. There was someone who was hired to do our authorization, someone who was hired to do all of our clinic stuff. And so once that old group, that big kind of private group went away, that kind of went away too. And so now we're kind of back to square one and we're building that up. So I think ultimately the direction we're headed in is kind of hiring our own front office person and kind of our own staff to do that. And, hopefully be able to leverage that into other opportunities as well. Having an outpatient practice is a huge part of our professional satisfaction and a huge part of making sure we're getting the kind of cases we want. So that's definitely something that you don't really learn in training, but we're focusing on hard to make sure that even though we're not in an OBL and even though the procedures we do aren't, in our own center, we still want to have the opportunity to do those kinds of cases that, IRs love to do and dream to do.
Absolutely. So are you doing things like prior authorization yourself?
So as of now, one of the people that was in that prior company had hired over, we pay them kind of PRN to help us out a couple of days a month, a couple of days a week to make sure the prior authorizations for those types of procedures are done. So that's going to be the process that we're going to continue to do. Like, I am not equipped to do that yet.
Me either.
Maybe I should learn how to do it.
No, I don't think I'll ever do that.
Yeah.
I'm also hospital-based, but have a full outpatient clinic, and most of my work actually is outpatient. But I mean, we have a clinic in the hospital, with a clinic nurse is there every day, and you find ways to make it work.
Yeah, I mean, I think one of the biggest things I've learned and understood is the physicians that are referring you don't care what transition you're going through or like what the staffing issues are or anything. For them, it's all about how easy is it for me to get my orders done. And especially if you're living in a big city, you have to make it as seamless and painless as possible. So that's kind of what we're really working on and spending a lot of effort into really optimizing that process. And I think we're early on in that process, but I think we're going to figure it out because me and my partner are like-minded. We're technologically relatively savvy and have access to some resources to make that happen.
Right. It's like, who's going to see my patient, who's going to do it fast, and who's going to make it smooth. And, I will say I'm biased, but I love hospital inpatient IR. People love to talk about, OBL only. And the cases you do in OBL are wonderful and the model is great. But doing a trauma case, in the middle of the night, those are hard to beat.
Yeah, I will say that they're definitely rewarding. And then the other big thing for someone young and early in their career, there's something to be said for having the resources you have in a hospital. The various tools, the wires, the catheters that you may not stock and have. Most OBLs don't stock like fully stock. There's just a different mindset on how you're running the business in OBL. So I definitely think early on in my career, when I was finishing training, I talked to a lot of people and I was like, I want to go directly into OBL. That's what I want to do. And a lot of people looked at me and said, dude, you got to do at least a little bit of inpatient stuff, like at least a couple years. And I was just like, I don't know, man.
I got the same advice. Like I had talked to this guy in an OBL in Georgia, and the guy was a stud. And I came out, I finished a pin, and I was like, I'm amazing. I'm the best. Like, there's nothing I can't do. And he's like, dude, you need to have a regular job before you do this. You need to learn how to do all this. And frankly, that's how I got really good. Was in my first job. Troubleshooting and working your way out of different problems.
Yeah, and I think it also depends on who your partner is. You have to go to a place where your partners are going to help you out and be resources for you and be available. There are times where my partner comes in on his day off for some of the cases I just didn't have as much experience with to help out. So that is also important because if you're going to go to a job where someone's not going to be willing to help you, then you might as well just do whatever because you're going to be on your own no matter what.
Yeah, I've been very fortunate. I've had 2 jobs, and in each place, I had mentors that, would really go to bat for me and help me do cases. And it was great, made all the difference. How do you guys are, it seems like it's not really tightly structured. It's you and your friend, a partner that are working really well together. How do you guys manage strategic planning and the business type decisions?
So I think we're lucky that we're relatively like-minded. And I always tell this to my partner, I'm like, you and me are like a puzzle and we fit together. And he doesn't like that analogy, but I think it fits exactly. And I think there are some things that are my strengths and I'm really good at. And there are things that he's really good at. And there are things that we both could do better at. And I think we fill each other's gaps in that regard. And so when it comes to decision making, there's times where I defer to him because it's kind of in his realm a little bit more. And that's kind of more on the clinical side, on the practice side. And then on the business side, when I went to college, I had a degree in business and I've always had kind of a business mindset. And I've always kind of understood and try to focus on that aspect of things. So on the business side, I try to leverage some of my experience, some of my knowledge. I have a sister who helped kind of a Mohs surgeon really build his practice up into a really large practice and worked in other dermatology practices. So she also has a lot of experience that I can tap into from the business side. And I'm also the guy who will slide into people's DMs and other physicians and stuff and other independent IRs, and I'll message them and I'll text them and I'll say, hey man, like I need your advice and this and that. So I collect a lot of information from people too that help me make some of those decisions. But we really are kind of like a 1-2 punch, and that really is what helps us do things.
So that's interesting. So what are some of the challenges that you face in independent IR that I may not see in a traditional IR/DR practice?
I think the biggest one is if you really want to build the outpatient practice, like it's stuff that's going to come out of your own pocket and out of your own time. So, you really have to go out and, for example, our deficiency was not having a front office person anymore, not having an authorization person anymore, understanding and learning that stuff, and then going to physicians, meeting them, talking to them, convincing them that they should send you cases. And then the other part of it is once you get the cases, doing them well, because especially for someone that's early in their career like me, someone sends me a referral for something and they don't get good outcomes, they're not going to send it to me anymore. And so that I have one shot to get it right. And so I think those kind of things are huge when you're independent IR, but more so just kind of trying to build the outpatient side of your business. The other part of the equation is that like when you're independent IR, now it's just two of you who have to kind of navigate the politics of the hospital system and all of that, rather than having like the whole system behind you. And that stuff is challenging in itself. And then it's even more challenging when both of you are young and early in your career, and either people don't take you seriously or people have kind of preconceived notions that you have to kind of fight and kind of you have to establish yourself and establish people respecting you or trusting you.
That's an important point, I think, because, this all happened like right after you finished training. Like, the jobs I've started when I came out, they were pretty well established. They had their own referral streams. They had diagnostic radiologists that were kind of teeing them up certain things. How did you go about getting the word out for you as a clinician and a proceduralist, but also for the stuff that you guys offer when it seems like you were both relatively new at this place?
The first part is I had the advantage of my partner had started 2 or 3 years before me. So he had established a couple of years of practice, and he had overlapped with someone else that was there for several years. And so those guys had established their reputation, and their reputation was go-getters. I got things done. And so my partner is the same way. He got things done. And then the other part of it was like when I came in, my program director in fellowship gave me really good advice, Dr. Cuban. He said, Josh Cuban, not Mark. That's good. But, he said, early in your career, take the easy ones, take the lobs, take the softballs, and don't try to go hit home runs. And so that's what I did. I really tried to make sure that the cases that I said no to, I had a good reason to say no to them. And the cases I said yes to, like I was very careful, very thorough, and always try to make sure I had good outcomes. And so you establish your rapport in the hospital and you establish your reputation that way. And then on the outpatient side, me and my partner just spent a lot of money on Canva. We built a website, printed out a bunch of things, materials. We go out and kind of pop into physicians' offices, try to kind of bring cookies and things like that. And we're just basically investing our own money into these cases to just kind of get our name out and get people to see us. But, ultimately it's kind of a time under tension thing. You really have to kind of put your time in. There's no replacement for that. Like no matter what you do, like if they don't see your name over and over again for several weeks, several months, several years, they're not going to trust you. So there's no substitute for that, but still putting your face out there, shaking hands, kissing babies, being on the floor when you're rounding on patients, being in the physician's lounge during lunch, talking to people, introducing yourself, all of those things go a very long way.
Yeah. I'm sure it's nice also, starting out, like I think, say you were to just go out on your own and open an OBL in a brand new city right after training, it'd be very hard to get patients from day one. You'd have some lean days, months, and years. It's probably nice having some stuff built in when you start,
100%. And when I was finishing my training, my goal was to do locums IR until I was ready to do OBL. And a lot of guys that were senior looked at me, they're like, dude, how are you going to get referrals? Like, who's going to send you referrals? And I was like, what do you mean? I'm going to market myself. Like, that's how I'm going to get it. And they just kind of looked at me funny. I didn't understand that. But now that I'm in a traditional job, I understand that. Like, it's not just marketing. It's not just like flyers and rep dinners and things like that. It really is people knowing your product, your outcomes, and what you do. And there's no substitute for that. That's just time under tension. You just gotta put in the work.
Absolutely. And it's much easier to ask somebody to send you patients when they've seen your work,
Exactly.
Are you guys doing any direct or indirect patient outreach efforts?
Not yet. So I think that's kind of the next arm. I think the first arm is having when someone calls our office or when someone sends a referral, we're having to build that up from scratch, right? So making sure that's streamlined. So before I spend hundreds of thousands of dollars on marketing directly to patients, I have to make sure that when the patient picks up the phone and tries to call someone, that it's going to be a very, very smooth experience. And so in the last month, that's changed a lot for us. And we're still kind of building that up and optimizing that on a day-to-day basis. So at this point, not yet, but I have friends who are practicing physicians who already understand resources on how to do marketing. I have a lot of friends that do digital marketing and things like that. So I think I have good resources available to us when we're ready to do that. But that's a big financial investment. And unless you can convert that investment into actual outcomes, into actual procedures or patient visits or anything like that, then that's just going to be money that's down the drain. And really the cost of doing digital marketing has gone up significantly with some of the changes in privacy and security with like Apple and all those things. It is a lot more expensive per impression that you make to try to do it than it was maybe 4 years ago, 5 years ago. So that's something that's in the horizon, but not yet.
So that's an important point, how you guys are getting paid, like the financial aspect. Are you paid, for the contract? Are you paid, by the day, or is it, by productivity? Like, how does that work as an independent IR who's working with a contracted group?
So that part, it is variable, right? Like it depends on how the contract is negotiated. And we kind of had an opportunity to do it production based. And at that point, we would have had to do our own billing and things like that. And that just is not, again, in our strong suit. So we didn't want that. It just so happened in this situation, it's kind of like a base salary that you have, and there's no production bonus, there's no production incentive, but it's a fair salary to where that doesn't change how my practice pattern or anything like that. And I think like in terms of anything that we would do outside of that, there are opportunities for independent practice or an OBL type scenario that are potentially coming up in the future where like the financial investment we make now may return. But for now, any financial investment we do in those things is more of a professional satisfaction, is more of building our own experience and skills, because the PAEs and the GAEs and the UFIs don't just come out of nowhere. You have to essentially pay for those, because the truth is, like, I found that even no matter how many hands and babies you shake and kiss, people just don't want to send their PAEs and UFIs unless they have some kind of financial incentive. And so in order for you to be good at them, you have to do them. And in order for you to do them, you have to spend money to do them. And the first time you do them should not be in an OBL. It should be kind of in a hospital setting. So
that's how I've done. All of mine have been in the hospital. So I'm biased. And you've got to do them to get good at them. People don't like to send them. Mine are almost always over 90.
Yeah, and I listen to a lot of BackTable, and I always hear like a lot of experts who've done years and years of training, or have years of experience in that particular service line, and the question always comes up, like, where do you get your referrals? And almost always, although they may have a couple of relationships with physicians that send them cases, it's almost always direct patient marketing. And so, like, I found that that's going to be kind of like the bottom line is some of those cases, people just don't want to give them up.
Yeah. How do you guys handle call?
So we're on call. We basically switch off. So we split our time to split the year between us. And so when we're on for day call, night call, and that weekends call. So it's just, either 7 days on, 7 days off, or 14 days on, 14 days off.
Pretty good. 26 weeks off?
Yeah. Well, yeah, essentially.
You're grinding for some of that, sure.
Yeah. Yeah.
That's cool. Nice. Okay. One of the things I wanted to bring up is, as I said, I'm part of a medium to large IRDR group, and my group has taken on a lot of these contracts, particularly for RP groups that have lost their contracts. And, there'll be a void, and these hospitals will say, we need radiology coverage. And they phone a friend and ask, like, do you guys know anybody? And in many circumstances, come to my group and offered us a tele-only radiology contract. And we've picked up a handful of these. There's some where we're providing IR coverage, but most of them we're just offering diagnostic radiology coverage off-site. Sounds similar to the relationship your group is in. To me, it just seems like it would be a great opportunity for independent IRs to take on contracts like this. I think these are going to be more and more common.
I think so, 100%. And that leads me kind of a topic that I'm a little bit passionate about as well. I think one of the things between private equities leaving certain contracts or renegotiating contracts, one of the big thing is, along with that, hand in hand with that, is the fact that a lot of groups are renegotiating their contracts with hospitals, period. And a big part of that is negotiating a stipend.
Yes.
I think one of the big things that's really important for interventional radiologists to understand and do is they should be in the discussions. Like a lot of times the head of the group or whoever's negotiating the contract is not an interventional radiologist like us. They may be an interventional radiologist who gave up interventional radiology practice 10, 15 years ago and it now sits on the board and just does diagnostic radiology and things like that. But true IRs that put in kind of the call and come in and do the case and things like that, those people typically don't have a seat on the table during those negotiations for the stipend. And so the stipend is negotiated, and it may be a good number, but there's no on the other side of it, on the group side of it, there's no discussion. Okay, but like, what is this stipend for? Is this stipend just to cover the diagnostic radiologist to read, or is this stipend also covering having an interventional radiology just on site? And so, in order for a diagnostic radiology group that's going to have IRs employed, in order for them to be able to negotiate the IR aspect of it, the IR aspect of the stipend, or decide how that stipend is broken down, an interventional radiologist like us should be at the table discussing that. And I found that that's not the case a lot of times. A lot of times these groups will go and negotiate these stipends and ask for this money and whatever, and then they'll just come to the IRs and they'll be like, okay, well, we've restructured it, we've got a stipend, so we're going to keep going here. And for example, I had someone reach out to me about a position. They wanted me to join their group, and they said, oh, we're changing how we do our call. We're going to have pods. And I was like, what do you mean a pod? They said, okay, well, the one IR is going to cover like 5 or 6 hospitals in this part of the city, so you don't have to drive too far. I'm like, okay, so are you going to pay me per hospital that I'm on pager call for? And the answer is no. Like, oh no, this is like this, you're just on call. Like, that's just part of it. And to me, it's like, well, no, like when you negotiate a stipend at the hospital, you tell them, like, just like your cardiothoracic surgeon, your vascular surgeon, et cetera, you pay them a stipend to be on call and to be available. What is the stipend you're giving the IR to be available to come in and do whatever case you need to do? I think that's a huge part of the things that I think that we need to be a part of and we need to discuss. I think that it's really critical. The reason I'm kind of going a little bit out of my way to discuss this is probably the one time we'll have an opportunity to renegotiate things and renegotiate stipends and contracts. And whatever is negotiated now is going to be almost set in stone, and it'll be a while before we're able to change things. So if you negotiate things in a way where the IR is left out of the table, is left out of the contract, and these things are not discussed now, then in the future, when the IR-DR group is having trouble recruiting IRs, they're not going to be able to go to the hospital and say, hey, you know what, we need more money to retain these IRs. They don't want to stay. Like, have that discussion up front. When you're going to talk about your stipend to keep your overnight radiologists and overnight tele and diagnostic radiologists and that, discuss what your IRs would want to stay in this job and for it to make sense, especially in the context of current market conditions.
I totally agree. I think all IRs should be getting paid for call anyway. Are you having to have those discussions with the hospital administration or with the radiology staff?
Initially, the way our situation worked out is we just had discussions with everyone. Everyone kind of talked to us and what we wanted. The original group that had the contract was not really as interested in what we wanted, and that was clear. So we didn't really get to say much. I think the group that eventually got the contract, I think they understood what we would want. And so they presented what we wanted, and we had an opportunity to discuss whether we were willing to sign on or not. Our situation was a little bit more challenging because we were initially told we don't have a non-compete and we can talk to whoever we want. So everyone was talking to us. And then later on, they came back and said, you know what, we actually don't want you to talk to anyone. We're like going back on that. And it wasn't on our side because in my contract, I had negotiated that out, but on their contract with the other parties involved, they were basically bringing that up. So it was more challenging in my situation, despite I had all the foresight I could possibly have when I negotiated my contract, but I had no way to negotiate the other side of it. So, but ultimately we did end up kind of exactly where we wanted it to be. So the net result was fine, but our situation won't be the same in other places. It may be the IR-DR group that's going to stay together, it's going to stay intact, but they're just renegotiating their stipend. And in that scenario, I think the group should put the IR in the table and give them an opportunity to say what they want to want to stay.
So moving forward for your group, I mean, what do you guys plan for things to look like in the next 5 years? I mean, are you guys interested in taking on more contracts, more people, or kind of stay put where you are and just kind of grow the business locally?
Well, I think the markets are changing dramatically, and I think that as more private equity contracts kind of blow up and as more opportunities like this come up, I think there's opportunities for it to grow. And whether I am directly involved in other contracts or not, or whether I am more so playing kind of a mentoring role for new IRs that are taking that position, I don't know, but I specifically don't want to take any more call or any more contracts directly. I have enough on my plate. Like besides the 2 weeks on, 2 weeks off, like I'm working on other things that take up a lot of my time. So I don't have the bandwidth to do that. But I think it's going to grow. I think more contracts are going to go in the same way ours has. I think it's only a matter of time. It's just a matter of like if the right kind of group gets it. Like for example, my group, I think they value the on-site interventionalists. So we are treated well. And so if groups like that come in and take those contracts, I think they're going to be successful. I think the groups that don't understand or value the on-site interventionalist, they're going to have the most struggle in retaining IRs and continue to service their contracts.
Totally agree. What's the market like out there for independent IRs who are looking for a job?
I think that's the big challenge is I think you have to be at the right time at the right place as of now. I think that I just so happened to get lucky that like I joined the group initially, it looked dire that the group was ending, and then it created a vacuum and a situation to kind of allow us to seize the day and get kind of what we want. But I get reached out all the time with other groups that want help and that, may offer some kind of similar contract. I think you just have to be available. You have to have good relationships with everyone in the city, know everyone, kind of establish your name, and then people will call you when a situation like that comes up. It's hard for like a de novo situation to come up, because if a de novo situation just comes up and someone calls you, like that means you're the only IR they've called. You're going to need someone else to split that call, like either you have a buddy that's willing to tag along with you anywhere you go, or you're willing to take 24/7 call until they find someone else, which I wouldn't hold my breath.
No, thank you.
Yeah.
All right, man. Well, that's about all I got. Is there anything else about being an independent IR that I think is important to cover that I didn't ask you?
I think that what's really important, especially as someone, there's a couple of things that I wanted to at least touch on. The first thing is, as a new IR, someone who's coming out of training or as an interventional radiologist, I think there's a very delicate balance that you have to strike. And the balance is knowing your worth and your value. Like in a hospital system, when you come out, you're going to realize that academic hospital practice is very different. In the real world, like the IRs are kind of the catch-all for everything. You're helping neurosurgeons, you're helping the neurologists. There are literally board certified neurologists who don't know how to do lumbar punctures. And so you're the only person that can do lumbar punctures. You do all the lines and catheters. There are intensivists who don't feel comfortable doing thoras and paras. And so you're available to do those things. And so you have to know your value when you're negotiating jobs and things like that. And the other side of that balance, that delicate balance, is being humble enough to realize that we are in a very lucky and unique situation that the market favors us as the employee rather than the employer. And so you have to vouch for yourself and push for things that are fair for you, but you also have to be humble and not rub everyone the wrong way on your way to getting that job right. So I think that's really important for new IRs that are graduating, is like advocate for yourself. You're very important. Our specialty is very important. It really helps the hospital move forward. A lot of hospitals can't function if they don't have an IR on site. And at the same time, like make sure you're approaching every conversation you have with people with a little bit of respect, and you understand that like the market can swing at any point. That kind of leads me to the fact that like there is something to be said about the difference between being in a hospital system and being employed by another group or having IR subcontracted rather than being totally independent. There are pros and cons. I think the big pro for me is I can focus on doing IR. I don't have to worry about insurances. I don't have to worry about, me doing a GAE on a patient and then insurance coming back 2 weeks later saying, hey, we paid you, X amount, but we're going to take that back because we actually don't approve this anymore. And those kind of clawbacks and all those things, like I don't want to focus on that or deal with that. I'd rather focus on doing good IR.
Totally.
And so understanding the pros and cons of every aspect of the types of positions you take is really important too. The other part is I think DR is still an important part of our training, and I wouldn't give that up. Like I think there's still opportunities to kind of use the DR aspect of your training and keep those skills up, because you never know how things will change. You never know how your goals or life will change. And I think it's a good skill set to have, and it also allows you to kind of earn a little bit extra money on the side.
Completely agree on that. And also think that, especially for people coming out, like don't be above anything, any kind of procedure. It may seem like scut to you, but it's not scut to a patient. And doing these minor procedures sometimes is the key to getting bigger ones.
Yeah, I mean, and to piggyback on that, I had an oncologist reach out to me about a intrathecal chemotherapy injection, and I was just kind of like, yeah, I'll do it. I want to say yes to everything, but I hadn't gotten any ports or anything like that. Obviously, everyone's competing for ports. For some reason, everyone else loves doing them too. And I said, yeah, I'll do the intrathecal. I'll help you with it. I'll help you. It's a new service line. We didn't do that in the hospital. I helped set it up. And the next week I got a text for, a couple of ports and other procedures that, allowed us to build that service line. So you're right. Like you cannot be above anything. You have to be, the 3 A's of being a good radiologist. You have to be affable, available. And I don't know what the third A is, but I'm sure it's important too. Awesome. Able.
Awesome. Well, thanks, man. I appreciate your time. And I know you probably have a busy day ahead of you, but thank you for sharing your day and your experience with us.
Yeah, I appreciate the opportunity.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legrizio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.